Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Yeah, and thank goodness for that, because it was just going to be me. The educational part would be very slim. I could tell you for a couple of stories, but that's about it. If you were with us last time on the show, and if you're brand new to us, all of our shows stand alone, but we try to have a start, beginning, and an end. And we knew that last week our show was going to be probably a two-parter, just because there was more information than we could put into an hour so that you would really understand what's going on. Okay, so Dr. Juliff is the medical director of Vein Clinics of Hawaii at veinclinicsofhawaii.com. And it's on, like the show just said a while ago, Big Island, Kauai, Maui, and here on Oahu. And Doc sees lots and lots of patients with venous insufficiency. So venous insufficiency, and what we've been talking about last show and this one, is about not the spider veins that are cosmetic and sometimes not some other parts of your system, but these are varicose veins and the other things that happen with them. And there's more treatments than meet the eye. And that's another pretty long introduction, Doc. But I guess people need to know that you don't just have, one hammer to build a house, that you come in and you take a look at me and you see what I need, and then you bust out whatever equipment you need. So that's what we've been talking about.
Yeah. It's been exciting from my standpoint, being a part of the world of vein care, which I didn't initially. I was doing heart surgery and vascular surgery for a number of years, and then over the past 8 or so years, I had decided to just treat people with vein disease. And it's been particularly exciting for me because there's probably been more advancement from a technological standpoint within the world of vein care than there is in any other facet of medicine that I know about.
Do you think that partially because this disease mostly sneaks up on people over a long period of time, that there wasn't a lot of urgency to look for something new because this is kind of what we do? But then somebody must have said, well, wait a minute, there might be a better way here. And that's why we're uncovering some of these things, which I'm guessing, on the other hand, for our listeners out there, if you were looking at vein treatment and vein surgery the way it used to be, hey, this is like putting a Ferrari next to a donkey. I mean, it's changed that much, not just the diagnostics of it. But here is what I think. More and more of our listeners and more patients, particularly new patients, are coming in because they learn that it is a profession that is really changing, that it's not like it used to be just 10, 15, 20 years ago. Big change.
Yeah, absolutely. Yeah. And, back then, back when all we had was surgical vein stripping and everybody had a family member or a friend or a mother of a friend or whatever that had gone through it, they knew it wasn't pretty and the long-term results were not that good. But for many, many years, as you alluded to, the problem of venous insufficiency was very, very undertreated, very underdiagnosed, and I think that, and also in many cases unrecognized. So there are many, many people out there that have gone untreated and need attention now.
Well, I remember, and it wasn't, and I've had a lot of discussions about this, including with you, Doc, and that is that it used to be, not too many generations ago, that somebody that was 60 was very old. And now 60 is, you're just getting rolling.
Yeah.
So that means that maybe this disease wasn't far along in most people back in the day. So I might have that, but I got a heart that's going to go before my legs go.
Yeah. That I'm sure is part of it.
Yeah.
The aging process is one of the risk factors of vein disease. The older people get, the more likely they are to have venous insufficiency. But probably the single most important feature of risk with respect to whether somebody is going to develop vein disease or not is genetics.
Mom and dad.
Mom, dad,
Grandpa,
grandparents,
grandma, sure,
aunts, uncles, and very commonly people will come in and we'll ask them about their family history, and a lot of people will say, no, well, I don't really remember.
Yeah.
Well, back in the day, people didn't check out their parents' legs that much, so a lot of it I think was probably not talked about. But invariably, the genetics are usually there somewhere.
What is interesting to me is that everybody's seen the new explosion of these people that are going to tell you where you came from, how many generations ago, ancestry this and ancestry that. I'm also guessing that because of a lot of people died a lot earlier, that sometimes cause of death maybe wasn't as big of a deal. So even though most of what we talk about with your profession is maybe not as life-threatening as a lot of other diseases are, but it certainly is lifestyle-threatening. And as we get older, isn't it true that with all the new ways to deal with this thing, diagnosing the problem is step number one, and then step number two is just choosing the way you're going to do it.
Yeah. And getting people to recognize that they might have the problem, because sometimes their symptoms are such that it's not immediately obvious that they have venous insufficiency. Venous insufficiency is sort of a general term. It means that the veins aren't functioning properly in our legs. Well, that gets displayed in a number of different ways.
Yeah.
Varicose veins is just one of them. So most people, when they have varicose veins, it's pretty easy for them to say, gee, I've got varicose veins, I must have a vein problem. And most of the time they're right. But there are many,
I was going to say, there are a few more signals that we can deal with as well. Huh?
Yeah.
And by the way, a lot of times, and this happens when someone is referred by their PCP to a specialist for one thing, because the symptom indicated that, it might be, wait a minute, the specialist says when the patient gets there, this is not mine. This guy's got a big venous ulcer in his leg, and I can't fix that. He's got to go to a vein guy.
Right. Yeah. So, some of the other symptoms that we commonly think about are heaviness, achiness, the legs get tired, easy, what we call easy fatigability or early fatigability. Your legs just get tired quicker than they used to. Muscle cramping. Something called restless leg syndrome. When you look at muscle cramping, for instance, a lot of muscle cramping is due to venous insufficiency, and especially in the older age group of patients, that can be terribly disruptive to their quality of life because they're getting up 2-3 times at night, and it takes just walking around, it takes a little while to get rid of those cramps, and it's hard to get a good night's sleep that way.
Yeah, and by the way, this is really funny because I was out at a social function, and somebody that listens to our show said, the next time you get a chance, would you please ask Dr. Juliff again about this restless leg? My son is so bad that we make him eat at a different table because literally he can't stop it. He doesn't even know he's doing it, and we don't want to scold him. And so I said, well, don't scold him. There are some things that maybe that are. What are some of the things that may contribute to that besides just the kid's nervous?
Well, yeah, in that case, it's probably, strictly speaking, not restless leg. It's more nervous leg. There's a lot of nervous energy coming out in a little kid like that. But restless leg, when we think about restless leg, there's sort of a spectrum. But for the most part, we think about the activity of the legs actually waking people up in the middle of the night.
Yeah.
Or it can be as simple as some people, when you're just sitting around, you're sort of subconsciously moving your legs and contracting muscles. And the reason that you get used to doing that is because muscular contraction enhances vein function, in blood flow. So you get used to, after you've been sitting down for, 20, 30 minutes, you start to feel like, gee, my legs are aching, and you start to move your legs. Well, that's restless leg.
Yeah, and by the way, this is a habit that's really good on an airplane flight. We're going to talk about that a little bit, but a lot of these things, these DVTs, these deep vein thrombosis, they are as a result of not moving that leg around a bit. So I guess that in some cases, one guy says, I only do it when I have to go to the bathroom. I said, why not? That's a nervous condition. Maybe if you're doing that, you're not thinking of what you really need to do, and that's going to go to the bathroom. Yeah.
Right, right.
But seriously, I think that since there are a lot of duplicity in symptoms that you're talking about in the legs, and in if somebody has bad veins, usually in their lower leg, there are some things that you can see from the outside that don't even look like veins, but might be an indication, hey, there's a vein issue going on.
Right.
What are they?
Chronic swelling.
Mm-hmm.
You know, people, when you walk around during the day, you see a lot of people with swollen legs, and most of the time they're not really paying attention to it. Discoloration of the skin of the lower legs. A lot of people think that that's due to diabetes or just being out in the sun, but often that is a repercussion of what we call chronic venous insufficiency.
Okay, here's where I can get one. I'm quite happy to discuss myself. By the way, in a lot of our shows, we're going to be actually talking to a lot of docs' patients, and they come up from all over the social economic spectrum, the ethnic spectrum, the age thing. I had. When you talk about discoloration and that, I had all three of those things. In other words, I had type 2 diabetes as a result of being morbidly obese at one time, a long time ago. I had venous insufficiency, and I had sunburn, and I had dermatological conditions. All the same thing, but and I actually had all the conditions. And I guess you find out sometimes, too, that you got to work with other specialists. Because this guy's leg is all jammed up. There's all kinds of things he needs to get help with.
Yeah, absolutely. Yeah. And venous insufficiency kind of goes hand in hand with some of those other things. For instance, particularly in obese people, there's something called lymphedema, which also can add to swelling. And lymphedema and venous insufficiency often go hand in hand and can, each one make the other one worse. But getting back to who gets it, we've talked about the fact that usually there's a genetic, basis for why people might be predisposed to developing venous insufficiency. But some of the other risk factors are people who have professions where they're on their feet a lot.
Sure.
And there's a lot of people out there like that, especially in a tourist-based economy like it is in Hawaii. A lot of people working for the resorts and working in housekeeping and et cetera, and they work hard and they're on their feet all day long.
I'm really glad you said that, because we have talked to, and a lot of docs' patients, male and female. We have a lot of, we've got friends that are dentists, and there's a good example, guys standing up for sometimes 30 years, 8 hours a day.
Yeah.
I have a good friend who for many, many years was the head guy at the porte cochere of a major hotel. He was directing the valets. He was Mr. Meet 'em and greet 'em. This guy was on his feet 10 hours a day.
Right.
Very little, no rest for the wicked.
Yeah.
They didn't get to rest when they were there. They could rest on their break, or they could rest at their meal break.
Yeah.
But this guy actually had the inability to continue working because of a venous condition.
Sure. Yeah.
And I know you see that all the time.
Yeah. The professions that we see are pharmacists, nurses, people in housekeeping.
How about hairdressers?
Hairdressers, absolutely.
Retail clerks.
And especially those people, hairdresser and a teacher, those are the kind of the quintessential example, because they're not only are they standing all day long, but they're standing in one place all day long. They're not walking around when people, and that's why we encourage people to get up and walk, because when they walk, the muscles contract, and that enhances, vein flow, blood flow through veins. But,
I'm so impressed. So glad that you said that, because I do know that a lot of us, and some of you out there, got to remind you, Dr. Juleff is the medical director of Vein Clinics of Hawaii. They've got a great web presence. A lot of work goes into that website. It's very, very easy to use. And if you want to hear something or ask a question, we have a way that you can do that. You go to veinclinicsofhawaii.com, and you can see some videos and everything else. I think that if almost everybody, when it comes time to whether it's threatening your livelihood, the great example right now, we look at some things going on in the hotels, people not getting enough money, having to work multiple jobs. If you go down from being sick on one job, that's one thing. But if you're trying to make ends meet and most of the jobs that you're working are active physical jobs. You are really up a barrel. You need to get this stuff looked at and treated.
Yeah, and that's why it becomes important to know a little bit about it. I mean, I'm not faulting people for not knowing about it. That's our job to get this information out. Part of the reason why we're doing this show. But and that's why we constantly are talking about other symptoms that aren't necessarily immediately connected or people immediately connect with venous insufficiency, to be aware of those symptoms and to just come on in and let us take a look at it.
Okay, we're going to talk about a couple of different tools today in a bit. That we if you were with us last time, we hope that some of you are carryovers. If you're hearing this show, we got into half of this last week. Even though our shows all stand up on their own, I think that what's happening here is that once you are diagnosed by Dr. Juleff, and given the ultrasound and talked to, that there is definitely there's some ways to get this looked at better than others. Let's talk about why you have invested not only time and money, but research and knowledge and schoolwork and everything else, learning to use all these different things that you do.
Mm-hmm. Well, it's nice to have different tools, like we've talked about. If you're a carpenter, you got a whole bunch of different tools. Not everything is a nail, so you need more than a hammer.
I got a funny story for you. My brother, I was hanging a painting. I was going to hang a painting on my office wall. And so I went into his office because he had a hammer and some nails. And then I came in, I was tapping the thing in, and he came in, he says, "That's my hammer." I said, "Yeah." And he said, "That's my finishing hammer." I said, "Well, this is kind of finishing." But it is, then I realized, okay, there's a wrecking hammer, there's a claw hammer, there's a lever hammer, there's a framing hammer, and there's a finish hammer.
Yeah.
So it's the same thing happens in your office. You have, by design, probably more than any of your competitors with the stuff that you need to get to the proper use of the proper tool.
Yeah, and most of them accomplish basically the same thing. Yeah. But we're using them, kind of like the hammers, in a little different situation because they work a little better, they're safer, or a little longer lasting kind of procedure, and that's why it is so nice to have a multiplicity of things that we can do.
Well, I can tell you, you don't want to hang a painting with a sledgehammer,
no,
or a rubber mallet for that matter.
Right.
But I am impressed because I think what happens is, and we talked about this in previous shows, that you may employ any number of these things. It's the well-rounded. But what I want to find out is specifically what sets some of them apart. So we group two together to me that sound pretty similar. One is called VenaSeal and the other is called Varithena. I know VenaSeal is something that you've been using an awful lot. What is that?
Well, VenaSeal is a newer device. Mm-hmm. It was just FDA approved at the beginning of this year.
Although it's brand new.
Pretty new. Yeah. Although it was, I take that back. It was FDA approved last year or the prior year. It was just since the beginning of this year that we've been able to actually incorporate it consistently into our, clinical armamentarium. But it's a device that does not use some of the aspects of the prior devices that we had. Mm-hmm. In hopefully the outcome is doing the procedure in a little safer, more comfortable, a little more appealing way for the patient. Now, how did we used to do things? Well, the devices that we have used mainly in the past, in the immediate past, have been heat-based devices. So why do we use heat? Well, we use heat because the goal in most situations is to close down the vein that is not functioning properly. Mm-hmm. The reason that we close it down is because of valve failure. We've talked about that before. These flow problems that arise basically occur because tiny little one-way valves inside the veins start to fail. And that's the genetic component. Usually we inherit the propensity for those valves to fail from parents, grandparents.
I look, by the way, and this is why you want to go to veinclinicsofhawaii.com. You can see some of this stuff. And the interesting part about it is that blood is so desirous of getting back up and getting fixed up in the heart that it's going to do like salmon swimming upstream. It's going to do the best they can. But I would imagine that after a certain period of time, even though some fish make it up the stream and they don't go back through the valves, that once it becomes a time when more is falling back than's going up is when you have an issue.
Right, exactly. As those valves are failing, then rather than the blood consistently moving upward back toward the heart, much of it, and sometimes most of it in that blood vessel, in that vein, is going in the reverse direction. It's going down. And when that blood goes down, it creates something that we call pooling of blood in the lower leg. And that pooling of blood then is the thing that leads to all of those symptoms that we talked about, the achiness, the heaviness, the cramping, the fatigue, etc. And if it continues over a very long period of time, then you get those secondary, bad things like skin changes, the darkening of the skin, the skin becomes very fibrotic, and ultimately ulceration.
I learned something extremely interesting. When we talk about ulceration, gang, we're not talking about the guy that get the peptic stomach ulcer. This is a hole that won't heal. I've had them, you've had them. And are they all venous? No. But if it's in the lower part of your leg, there's a pretty good indication. If you have something that's not healing for a long period of time, you have some sort of a vein issue in that leg.
Yeah. And that's the crux of the issue right there. If you have an ulcer on your leg that is not healing the way that you would normally think that it should heal.
And by the way, doc means an ulcer is a hole, right? So you're looking at a hole. I know there's a lot of other things you're thinking of, but it's just a hole. You keep putting a Band-Aid on it. You keep putting, bacitracin or whatever heebie-jeebie on it, and it doesn't fix.
Yeah. An ulcer basically is skin breakdown. You're no longer in an area on your leg or wherever, but on your leg you have skin loss, and the skin is not healing the way that it should.
Gotcha.
And again, either it's not healing, or even in many cases, it's actually getting worse. Rather than getting better with time, it's getting worse with time. Well, if you see that, then there is something amiss, and it needs to be investigated.
Yeah, and by the way, I because I had this, knock on wood, it's a hard counter, I've become more and more aware of it. And particularly, and I know, Doctor, this means a lot to people in your profession. I was looking at, in our homeless show that we do, the number of people that are homeless that have conditions, venous conditions that are so bad, it's amazing that they can even stand up and get around. This must be very, very challenging to fix if it gets let go for a long time.
Yes. Yeah. The worse it is, the little more challenging it is. There's no question about that, because as time goes on, there are changes to not only the skin, but the venous system and the lymphatic system that just won't heal eventually, even given more time. Or even if you fix what you can, you're never going to get back to normal.
So one of the main tools that we've talked about before, and if you were with us on other shows, we talked about the treatment with heat. And there are alternatives. We also talked about a whole other treatment. But today, let's talk about, we went from the heat, which has been the tried and true for the profession for a long time, to Venus. What's the difference between having something heated and VenaSeal?
Well, VenaSeal relies on a biologic glue, basically. We sometimes refer to it as super glue.
Yeah.
And it's a substance that is called cyanoacrylate. That's the
Oh boy,
chemical.
that's right. I just fell by the wayside on that one. One more time.
It's cyanoacrylate.
Okay, yikes. Okay.
And actually, it's a glue type material that has been used in the past in many different medical settings. It has been altered a little bit by the company that has developed it to make it a little more useful in this setting.
Gotcha.
But basically, it's a glue. Yeah. Now, in the past, and we're talking about all new era vein care kind of stuff. But in the past, we've used these thermal devices like laser and radio frequency. And those are all, based on threading either a laser fiber or a radio frequency catheter
up into that vein,
into the vein,
or down into that vein in some cases. Yeah.
Most of the time up, but up into the vein and positioning it wherever we need to fix what we need to that we have to. This the VenaSeal device is a very similar kind of looking device. It looks like a big catheter. Long catheter. It's still pretty small. But we thread that into the vein and up to the level where we want to start treating. Again, through that catheter, then we place little droplets of glue, basically.
Yeah. In a different procedure, you get that catheter in there. Now you're putting up a solution, or you're putting up something that's going to go up and melt something.
Right.
But this one here is going to actually glue it
shut. Yeah. So rather than relying on a sclerosant, which would be a chemical that's going to close the vein, or rather than relying on heat, which is going to internally cauterize the vein, we use this glue.
Must be a tiny, you'd have to, in your mind's eye, to see it. And we're talking about like a pinhead drop of it, right?
0.1 cc's.
Oh, jeez.
So that's really little. That's small.
Yeah.
It's amazing how little of the product you really have to use.
How adhesive is it, Dr. Juleff? How efficient is it? I mean, you've heard the story, I'm sure, of kids playing with super glue, right? The other super glue. And they get their finger and their thumb together.
Right.
That has to be almost. You almost need a jackhammer to get that thing open.
Yeah. It's about like that.
Yeah.
As soon as the glue hits the biologic tissue and blood, it sets up almost nearly instantaneously, and it achieves its ultimate strength over a very, very short period of time.
We're talking what, minutes?
Minutes. Short, almost instant.
That's really terrific. And now, obviously, there's no one quick fix all for everything. But what is the most typical specific use that you think VenaSeal does?
Well, for VenaSeal, it's a little bit of a patient preference. So what we're doing now is we're offering a variety of different things to our patients. Now, some patients need one in particular rather than the other. Now we kind of have to, tailor that toward specific problems. But in many cases, we'll have the patient, get involved in the conversation. Some people don't want new things. Some people want tried and true. And for those people, we use the thermal devices, the radio frequency.
It's like the guy that says, "Listen, I love my flip phone. I don't want this. I want a flip phone. I don't care where I have to get it."
Right. Yeah. Exactly.
But I think that maybe some of that is based on the loyal, good customer or good patient that had something done 10 years ago, and it was so successful. 10 years later, he wants that again because it really worked. Man.
Sure.
I don't want to try this newfangled thing.
Yeah. That could definitely be a scenario. Yeah. But so what are the advantages? What are the potential advantages of something like VenaSeal? And getting back to the prior device that we talked about, Clarivane, it also is a non-thermal, non-tumescent device. So that means that we, number one, don't use heat. And because we don't use heat, there's a couple things. Number one, we don't have to use a lot of numbing medication.
I was going to say that must encompass the fact that some of those other procedures, in order to make the patient be able to tolerate the treatment and not have an unpleasant experience, is you numb the area with a lot of stuff.
Right. Yeah. And with the thermal devices, it's absolutely necessary, mandatory that we use a lot of anesthetic. Otherwise, the patient will have a lot of pain.
Yeah.
So we don't have to do that. Now, there is a certain amount of discomfort that people might have when we use the a large amount of anesthetic. And the anesthesia that we use is something called tumescent anesthesia, and that just refers to the fact that we've got numbing medication, similar to the stuff that you get when you go to the dentist. But it's in a lot of saline. It's in a fairly large volume of fluid. And we're injecting a fair amount of fluid into a patient's leg around the vein that we're treating.
I actually had a question the last time we mentioned that on another show, and I thought it was important. I get that, that when you go to the dentist, most of the time, you may think you're numb from your head to your toes, but actually he only really needs to numb the lower left jaw if that's where the work's being done.
Right.
And so, it feels really weird, but it seems to me that what you need to do and what you are doing is it is a large area that has to be numbed.
If we're working on a vein that essentially might go from the groin all the way down to the ankle, we have to anesthetize or numb nearly the entire length of the leg around the vein that we're treating. So that turns out to be a fair amount of numbing fluid that we're injecting into somebody's leg. And it doesn't really hurt. I think it's more of a pressure kind of sensation, but it's different than what you have felt before. Normally you don't feel stuff being injected into your leg.
Well, darn well, when you finish at a dentist's office, the last thing you want to try is drink a soda pop. Because it's going to be in your pocket.
Right.
Your whole face doesn't work. Yeah. And I do know that the work done at the Vein Clinics of Hawaii is done on site. It's so less invasive than it used to be. 99% of the patients come in, they get their thing done, and they're out of there. How long does it take this mass area of numbing to not be numb anymore? Or is it a non-issue because it's not the muscles that you're using to walk around? In other words, can you stand up after being numbed?
Yeah, exactly. Yeah, the medication, we're really deadening the sensory nerves, not the what are called the motor nerves.
Okay,
the nerves, the nerves that.
In other words, next time I do this, I can drive home. It's okay to drive home.
You don't have to roll out of the office. No, but so that's an advantage.
Mm-hmm.
Now the other advantage is with respect to the fact that we're not using a heat-based device, is that when we use heat to close a vein, there's always a risk of damaging other surrounding tissue. Mm-hmm. So, we want to damage the vein that we're treating. We want to damage that and make it close down, but we don't want to damage the artery that's next to it.
Yeah.
Or, the other thing that often can become damage if we don't have things separated enough would be skin. I mean, a thermal device can burn skin. A thermal device can damage surrounding nerves. So all of those things have to be considered.
Yeah. By the way, there's so much going on in there. You've learned in previous shows, and you can get to veinclinicsofhawaii.com and learn a lot more. But there's a lot of people, a lot of stuff in there sharing that space. So while you're working on the vein, there's a lymph system, there's this and there's that. There's all these other little programs going on. You don't want to spill stuff on any of them, do you?
No. Yeah. So if we remove the thermal part of it, then we remove those potential risks.
Right.
So that's and that's one of the things that has been accomplished with these newer devices to get rid of the thermal part. So the risk of, for instance, nerve injury essentially goes down to nearly zero because there's nothing that's going to damage a nearby nerve, even though it might be close by, because the glue is staying all within the vein itself.
Yeah, to me, that's another fascinating. By the way, it's like how many arrows do you have in your quiver? And we're learning them as they go along. And I want to make sure that, and we'll circle back, but also, since I said earlier that VenaSeal to me sounded a lot like the other V, and that's a Varithena. And that's another form of injection. I read up on it a little bit so I could ask you some of the right questions. I would imagine that for most patients that is the preferred treatment, some sort of injection into a vein that's not a big problem vein. Is that I don't know if I'm even saying it right, but you know what I mean, that maybe this Varithena is the sclerotherapy that I've learned, where you inject something in there.
That's true.
Yeah.
Varithena is one form of sclerotherapy. However, it is a manufactured product. We have found that it's a fair bit more effective than most of the other things that we were using before.
Which would maybe a saline solution with some medicine in it?
Right.
Yeah. Okay.
And the Varithena, it comes in a little canister. You know, this is a metallic canister, and you mix it, and then you pull it up into a syringe, and it's a foam.
Yeah,
It looks like it's white and it's a foamy kind of substance. Now, we've used foam before. You know, when we're doing sclerotherapy, whether it's spider veins or medium-sized veins or even larger veins. When we do sclerotherapy, sometimes we foam that solution. So we kind of push it back and forth between two syringes, and we introduce air into the solution, and it foams.
So I'm thinking scrubbing bubbles are coming out of it.
It is scrubbing bubbles, and and for that same or along those same lines, the scrubbing bubbles are more effective in creating what we want to have created inside the vein, more so than just injecting the medication. Basically, what it does is that those air bubbles make the medication attach to the inner lining of the vein at a little higher rate.
Gotcha.
Than if you don't have foam.
Okay, now here's one that comes. This is out of left field, but here's one that a lot of people want to know, and that is, let's say that I've been diagnosed and treated with the ultrasound, and I got a big vein issue, and one of my veins, you got to fix it. The vein's still being used. Maybe it's not functioning properly, but it's still being used. Does this mean that there is in vein surgery a lot of blood?
Very little.
Yeah, I've heard you say that before, and I know that people are curious about that. You would think that, all right, I got to go fix this vein that's no good, but when we get into it, cut it over, the blood's going to go all over the place.
Yeah, the reason for that is, number one, we do everything so minimally invasively anymore.
Yeah,
we don't make incisions. We make little, needle puncture sites.
Entry sites.
Entry sites. Yeah.
I love that.
And so for that reason, there's very little bleeding. And also, getting back to the tumescent type anesthesia that we use, part of what we put in that tumescent anesthesia is a medication that causes blood vessels to contract.
Yeah.
So when we're using that, actually, that even accomplishes less,
further
bleeding.
flow of things. Yeah, sure. Yeah.
So that's one of the advantages. That's one of the advantages of using tumescent anesthesia is the bloodless nature of it. But very little blood loss, very little.
Yeah, and there's always, and this always comes up. I don't care if you were listening last week or this week, or you go onto the website veinclinicsofhawaii.com and let your fingers do the walking and discover some other stuff. It's totally fascinating to me that it is that way, because one would think that, oh man, you cut yourself with a knife and here comes blood all over the place. That must mean that you're cutting a lot of things. I mean, you must cut. In other words, for when you get cut, where the blood that comes out of a cut, where's the blood coming from? Arteries and veins, or both?
Both.
Yeah.
But it depends where it is. If some parts of our body, even the skin, is much more vascularized, has much more vasculature than others. For instance, the scalp. I mean, you don't need much of a cut on your scalp to say it's have a lot of blood loss. And that's basically because of, the skin of the scalp. It's a little different than, most of our other skin is very vascular, a little thicker. And so they're going to get a lot of. Now it depends on how deep the cut is. If you're cutting very deeply, you might be hitting very large arteries and veins.
And as we get older, I often tease my grandson said to me, hey Papa, what's all those things on your arms for? Well, because I'm getting old, and when you bang your arms, they bruise pretty easily. And I do know that in many cases, some of that's treatable and some of that's not. So the same question would have to be asked of, as we get older, does it take less to damage a vein? You know, I mean,
well, it takes less to damage your skin, and in so doing, the veins that may be associated with the skin in that area. And that's just because, as we age, we lose the elasticity of the skin. We lose the collagen in our skin, and all of that can make it a fair bit more fragile.
I heard from another guy. This guy's a friend of mine, and he's 3 or 4 years older than me, and takes blood thinners because he's got AFib or something like that. Anyway, he takes a lot of blood thinners. But he says the downside of that is the smallest hole. It's like a faucet. And he really has to be very careful. And he said particularly one, and maybe you can comment to this, sometimes I know it's a diabetic side effect, and sometimes maybe it's venous insufficiency, that sometimes you don't feel a cut, and that you can wake up with a shoe full of blood or a bed full of blood. It could be a problem.
Yeah. Especially diabetics who don't have, they've got neuropathy, they don't feel their feet well. But spontaneous bleeding can occur also in venous insufficiency, and it's not painful. No, it is not.
Yeah, and by the way, I had another one, since we're talking about things, and that is a guy's taking a shower.
Yeah.
And all of a sudden, blood squirting out of his leg, and he flips out and he runs.
Yeah,
and
not the thing to do.
No, and then he put a towel around it, and he's got to go to the doctor. In actual fact, and I remember you said this before, if this happens to you, first of all, you can please explain why it happens. I'm taking a nice hot shower, and all of a sudden I'm seeing blood squirting on the wall. What's going on?
Well, most of the time, there's something abnormal about the skin in that area. Now, and often it's due to tiny little spider veins that become very, very superficial, and the skin in the area of those spider veins can actually start to thin out. The longer they're there over a very long period of time, the skin starts to thin out, and then it doesn't take much for that outer layer of skin to come off or to break down, and the vein is there exposed, and it can bleed a lot, even though it's a tiny, tiny vein.
That's amazing to me.
Yeah.
Where's all that blood come from?
Yeah. So, typically it happens in the shower, and that's because of the water and the heat is, kind of loosening or softening up the skin, and it probably makes it a little more likely to come off completely and create the bleeding. It can be very, very intimidating.
Yeah.
Because not only are you can lose a fair amount of blood through those little veins, more than you think, and then also you're in the shower with all the water.
Yeah,
and
it makes it like Psycho or something.
Exactly.
But wait a minute. But here's the thing that I thought was fascinating. Dr. Gillis says, well, what do? Elevate it.
Yeah.
You just stop what you're doing and get it up in the air, because it's harder for it to hosing blood out when it's pointing up in the air.
Yeah. You don't want to start running anywhere. But the lucky thing is that often it is a vein and not an artery. And veins are low pressure. Our arteries are higher pressure because the heart's pumping blood through those arteries. But veins are low pressure, so essentially you could probably lay flat and put your foot way up, and that alone would probably make it stop. Yeah. But basically, you elevate your leg, you put a little pressure on it, and it'll stop.
Yeah, and you know what? The reason I asked that is because I know a lot of you flip out and panic. And that's why I asked earlier the question about when you're doing a procedure in your office, does it bleed a lot? And I think that people will be, pleasantly surprised that no, it doesn't. And I guess that also right after a procedure, you keep a pretty good eye on a patient for a while just to make sure that there's nothing that happens that way.
Yeah, absolutely. Sure.
Yeah.
Yeah.
Okay, so just so that we sort of get a grip on this, Varithena.
Yes.
It's the injection, but it seems to me like it's a newer kind of an injection. It's a little bit different.
Right. Yeah, exactly.
Re-explain that, please.
We've had
the bubbles.
We've had injection sclerotherapy for years and years. And a lot of vein disease, especially in Europe in the past, was treated primarily with injection sclerotherapy. So that process has been around for a long, long time. Foaming the medication has been around for a long, long time. But this is a little higher level, higher technical kind of level of the development of this medication in a foam sort of fashion or a foamed state that works quite a bit better than the other types of foam that we've had in the past. And it's kind of nice because the foam is, the foam kind of moves in its own sort of fashion, kind of like a fog through the streets of England. It'll just kind of move wherever it needs to move. And the foam is a very stable kind of, solution. And it pushes the blood out away, which is what you want. You want to get the blood out of the area. And again, it has a sclerosant type effect on the surface of the vein that you're injecting into. And ultimately, it creates an inflammatory response on the inner lining of that vein, which is what we want because that will ultimately allow it to contract and then for the walls to stick to each other and then consequently for it to close down.
And, gang, if you go to veinclinicsofhawaii.com, you can see some of what we're talking about, and you can see links and connections. And you can find out about some of the services offered there. Lots of stuff, by the way. Some of it's really fun stuff. We're going to do a show one of these days on some of the cosmetic fun things that Dr. Juliff gets to do at Vein Clinics of Hawaii. But what we're talking about here, and it always comes up, is making sure that you get the proper kind of a treatment in sort of a way. There's a wonderful thing going on now, Doc, with strokes, because what they're doing is they're showing the signs of a stroke. They got this thing, this fast, right? And it's the face, it's the sag, it's the voice, and it's a pretty good indicative thing.
Right.
What about the question that came up? I don't even know why I didn't remember to ask you this earlier. But when you have to apply a tourniquet to something, if something is major cut and you don't know what to do, isn't there a real danger in having that thing on there for a very long time? What can it do to the veins and arteries?
Well, the main drawback to putting a tourniquet on like a limb or something is that you're cutting off you're stopping the bleeding,
but you're stopping the blood supply to that leg, aren't you?
Exactly, yeah. And you're stopping all of the blood supply. If you've got a tourniquet on tight enough such that it's going to stop the bleeding of a fairly large blood vessel, which is what I assume we're talking about. So and you can only do that for a period of time. If you keep it on too long, you're going to start to have tissue death because of lack of oxygen getting to tissues.
Isn't it amazing how quickly that can happen?
It is.
Yeah.
Our body needs oxygen, and if you eliminate the oxygen, it doesn't do well.
I think the question sort of came up because even though we consider ourselves really close to everything here on Oahu anyway. You have offices on the neighbor islands. I know that there's some people that get hurt or injured, and they are far away from a place where they can get treated. So they should know that, stop the bleeding, put pressure on it. But before you put a big old tight tourniquet on, you better know, how often do I have to let it loose a little bit?
Well, in that, I think you hit on the key there. A much better way to control any bleeding is to use pressure, no matter what it is, no matter how big or how small. We were talking about before when a spider vein starts bleeding. It doesn't take much pressure to control that. But if you've got you can hold pressure on a pretty major artery, and you can control that at least long enough to get the patient to the hospital,
someplace, sure,
or wherever it can be, wherever that problem can be addressed a little more, specifically. But tourniquets in general it's a two-edged sword.
Yeah. Okay. And one of the things that I want to make sure we cover, because this you can visit any of the clinics, particularly, any of them, and learn more about it. But one of the things that we haven't talked about at all today, which is a miracle to me because I almost need to talk about it on every show, is compression. And that's with these garments, these compression socks. From what I understand, some of the treatments that you do, right after that, it's good to wear compression socks. Explain why that is.
Well, because we have manipulated a vein in one way or another, and we want to basically make that vein close down. That's the goal in most situations. And with most of the devices, and I was going to mention this before when we were talking about VenaSeal, but in most of the devices, compression from the outside and collapsing the vein that we've worked on, because we want the walls to stick to each other in a post.
Yeah.
That is beneficial.
It's helped because you're compressing.
Yeah, it's the quality of the outcome of the procedure is enhanced by having that external compression on. Now, the one procedure that we've talked about over the last couple of weeks that we don't have to use compression stockings is VenaSeal, the biologic glue device.
Yeah, the super glue. Yeah,
and which is another one of the appealing features to patients about that particular device. I mentioned before that often we kind of leave the final decision if there's a couple of different things that we feel would be adequate in whichever way they would go. We often ask the preference of the patient, and one of the things that patients finds appealing is that they don't have to wear the compression stockings post-procedure.
But I have to tell you, I went kicking and fighting and screaming. I'm almost embarrassed because earlier today, when Doc and I get together to do the taping, sometimes it's in the evening, even though it doesn't matter when you're listening to it. But earlier today, I went home and put my legs up and took my compression socks off. And I'm on my way out the door, and I think I'm going to be late. And I thought, I'm just going to pass. And I think that when you do that, you run the risk of not doing it. And I do know that we should spend a minute explaining, because some people are just angry because they cost a lot of money, they say. But don't we have to think of it not as a sock, but as a medical device?
Oh, definitely. Yeah. I mean, the construction, the R&D that went into developing these things is pretty incredible. They really are constructed in a very scientific way. Yeah, they're a little pricey, but they're worth every penny of it in the long run if you need it. Compression stockings work. Because it's a graduated level of compression. We call it graduated compression, and that is that the pressure is higher the lower you go, and then it diminishes a little bit as you come up the leg, and that enhances the flow of blood and fluid out of the leg upward.
What I think is fascinating, though, and I know you've seen it as well, is it's starting to creep into sports. I mean, they're now using compression garments on their legs, and they have them in neon colors. They have them in all kinds of. But it is it's a non-steroidal, or it's not a performance enhancer. It's just something pretty natural. But doesn't it sort of show that if you're using that for healthy veins, boy, if you start using for unhealthy veins, you're going to get some progress.
Sure.
Yeah.
Well, and there's been some, with respect to the compression that runners and athletes are using, especially on the lower leg, they're doing that for muscle recovery. There's been some science behind the idea that people who do wear compression in athletic sort of situations, the muscles recover from oxygen deprivation quicker than they otherwise would.
Pretty cool. And that's why you got to think of that. You can check that too at Vein Clinics of Hawaii. www.veinclinicsofhawaii.com is a way to do it. I want you to consider, now that some of you I know are very inquisitive, we love your input. If you want to hear something on this program, it's pretty easy to do. You can drop me an email anytime to the Mike Buck Show at gmail.com. But more importantly, get hooked up with Vein Clinics of Hawaii and make sure that you go in. And I guess your first consultation and taking a look at whether or not somebody even needs treatment, that must be very gratifying to you as a doctor when somebody comes in and says, I probably don't need you, but I'd like to know.
Yeah. And we hear that all the time. And most of the time the answer is, yes, you need us. And the other thing is, and this is another concept that we have to fight all the time, is that people can have pretty substantial vein problems and even have, huge varicose veins or, surface kind of things that are problematic. And they come in and they say, well, I don't know if I'm just being too vain, to come in and have you look at this. But, I mean, if you have changes like that superficially, invariably you have an important medical problem.
And that's where we're going to leave it today. Not to scare you, but to scare you just a little bit. Go to veinclinicsofhawaii.com, tell your friends about our show, and make sure that you follow procedures and get those veins checked out.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.